Hello and welcome to our rapid fire session on continuous diffusion of oxygen, sponsored by EO2 and Braemed. Our speakers today are myself, Karen Campbell, Rosemary Hill, and Kathy Mutch. All three of us are NSWOC nurses, and Rosemary and Kathy are CNA certified NSWOC nurses. We're going to be reviewing some current cases. I'm going to be talking very quickly and giving you an overview of the evidence related to continuous diffusion of oxygen. And then we're going to be talking about some frequently asked questions. I'm going to turn it over to Rosemary Hill.
Hi, everybody. Thank you, Karen, for that great introduction. And I'd love to share this case with you about a diabetic foot ulcer of a gentleman. He was a 49-year-old male with fairly poorly controlled diabetes and a relatively high, as you can see, hemoglobin A1C. But now he had osteomyelitis, and he had this wound on his foot. And interestingly enough, he was seen by several practitioners, specialists, and it was deemed that more than likely he would need a below-knee amputation. And so I include this slide to show you that actually that's his electronic health record that says, yes, high likelihood of a below-knee amputation, which of course was very upsetting for him. And so he wanted everything done to preserve his foot. And so there was a debridement, then we had a VAC application to his particular wound. You're going to see some photos coming up. But you know, after the debridement and 2 weeks of VAC therapy, there we are in the OR with the orthopedic surgeon who did the debridement. 2 weeks later with VAC, you know, we really weren't seeing a whole lot happening. And so in an effort for limb preservation, we said, you know what? How about if we try continuous diffusion of oxygen? And so off we went with applying a special dressing with oxygen diffusing right to the wound bed. And you're going to see in this next series of photos how the granulation tissue just really picks up. And you can just see a robust wound bed in response to the ongoing 24/7 continuous diffusion of oxygen, which in this particular case, it was certainly limb salvage. At some point, we often thought, are we going to have to do a skin graft? But we even avoided skin grafting. And you'll see right up until, I think I have another photo in March, where you're going to just see it's smaller and smaller. And so that is the firsthand results of a person who had a limb-threatening diabetic foot ulcer, and how it was really quite dramatic how the wound bed and he responded. Now I want you to know as well, of course we looked at all the other variables. Indeed, we treated his osteo. I even had a little bit of light compression. We also, of course, controlled his blood sugars. So we moderated all of those factors as well. But you can see, look at April, we virtually almost have a closed wound just as a result of the oxygen therapy. We did, I think I used oxygen for 2 months and then moved to a hydrophilic blue type of dressing. And then since then, he's just been on an absorptive dressing to conclude his wound healing. Thanks, Karen. I'm going to hand it over to you.
Alrighty, so actually thanks, Rosemary. I'm going to talk about a fully blinded randomized controlled trial that you can actually get off of our EO2 portal. And it is actually comparing continuous diffusion of oxygen to moist wound healing. And you can see in both arms, people were offloaded and had the very same dressings. We actually, in the screening period, excluded anyone who, with offloading, debridement, and moist wound healing, was healing very well, and only included people whose wounds were not closing quickly. The primary outcome was complete re-epithelialization, and as you can see, our active group closed at almost over 2 times what the placebo group closed at, and that was statistically significant. Interestingly enough, as the wounds became bigger, EO2 was more effective. And it was not something that we anticipated, but wound healing did improve. And so in conclusion, we found that we had a rigorous, fully blinded study. We had subjects and physicians were blinded. No one knew if they were actually getting CDO or not. And we found that CDO closed significantly better and faster. It seemed to work better in larger wounds, more chronic wounds, weight-bearing wounds, and appeared to reduce more severe infections. Now I'm going to turn it over to Kathy Mutch, who's got some really interesting cases to share.
Thank you. I'm pleased to be able to describe to you some of our experiences with continuous diffusion of oxygen. The first case study is a 69-year-old male with a history of venous disease. He wears his compression hose. He does have some superficial varicosities and some stasis dermatitis bilaterally, as well as edema, but no history of DVT. History of liver cirrhosis. He came to our clinic March 11th with a painful lesion on his left medial leg. It had been there for about 2 months and it started as a black dot. He was on antibiotics and his ABI was done 1.27, and we requested a vascular surgeon consult. He saw him and felt that it was a venous ulcer. So initial picture of the wound. During the March 11th to April 9th, we treated him using debridement. He continued on his antibiotics. He wore his compression hose or was wrapped in 2-layer compression wraps. His topical therapy included silver, gentian violet, and foam. On April 9th, he arrived in excruciating pain. He was sitting in the waiting area and could barely make it down to the clinic room because of the pain. He hadn't slept for 3 days and he was truly miserable. EO2 was initiated. He did not appear to have infection process happening, so he was not assessed or not started on antibiotics. The EO2 was initiated and he was continued on 2-layer light compression wraps. You can see where the wound did show response to the previous treatments, but the pain was intense. June 26th, he had 0 out of 10 pain and the wound is obviously healing well. After that initial visit where he had been so miserable, I did call his home, check with him, and already within a day, he was able to get some sleep and the pain was easing. And within a week, it was only pain with treatment. July 3rd, you can see that it's just a tiny scab now. The wound was really healed nicely and EO2 was discontinued. And a week later, very nice looking healed wound. Unfortunately, on his July 3rd visit, he told us about a new painful ulcer on his right leg. To look at it, it was quite innocent looking, the picture on the left, with some necrotic slough in it, but the pain was just like the pain in his left leg from before, a 10 out of 10. So we immediately began EO2 on it, and within a week he was totally pain-free and the wound was fully granulated. Our next case study is a young woman in her 30s with a history of drug abuse, hepatitis C, QT prolongation on methadone, native valve endocarditis, chronic anemia, PTSD, ADHD, depression, borderline personality disorder, and a lengthy 4-year history of a lower leg ulcer, for which I had seen her off and on. She was sometimes lost to care, but would sometimes come in and would be septic and in ICU for a period of time. On admission, there was lots of eschar, not really granulating wound. Her pain scale was, she was in a pain crisis, partly due to some changes in her methadone treatments and pain management, and she was totally hypersensitive to any stimulation. As part of the team effort, the addiction counselors and addiction physicians were involved with her care, and we had her admitted so that the treatment could be followed carefully. This was her initial photo on when she came in, and you can see lots of eschar, and there's no granulation really occurring. So on the top left is going to be that original photo, and the larger one is going to be the progression of the wound. So you can see that the eschar is starting to soften a little bit. The oxygen is great at hydrating the wound, and it's starting to lift. The other thing you might notice is there's some color changes to her peri-wound skin. You keep an eye for that as we progress along as well. But there's buds starting. She wouldn't allow any debridement up until the March 25th point, and you can see where I was able to debride some of that eschar off and allow for some healing to continue. The wound edges are coming really nicely. You can see a good attachment. In this wound, there's granulation tissue. It's moist, which is very common when you're using continuous oxygen therapy. You'll have an increase in moisture, and the granulation process continued quite nicely. Good edge, and the wound is contracting at the edges. So we were able on May 1st, she had skin grafts done, and those took very nicely with good healing process.
Thank you, Kathy, for your description of those two cases, which leads very nicely into a pilot study that EO2 did on the impact of CDO on pain. And what we found in this pilot study is that all patients reported significant pain relief, and pain relief was fairly rapid, often by day 4. Almost 40% of them were absolutely pain-free. 52% had a greater than 75% reduction, and 91% experienced noticeable pain relief. And CDO enabled the actual stopping of narcotic painkillers, which in this day and age of opioid addiction, I think is fairly significant. But not only did it help with pain, but 83% experienced significant closure. And in the wounds that generally did not close, pain relief was dramatic, and 75% were pain-free by the first follow-up visit. And so a very important clinical adjunct that we as wound nurses need to be aware of. So let's go on and move on to frequently asked questions. And these are questions that we as clinicians working with EO2 get asked a lot. So how does increasing oxygen impact the wound locally? So we all know that oxygen in the air is around 21%, and the oxygen that's delivered through the EO2 unit is 100%. So there's the potential for a 5-fold increase. And if you think back to Henry's law, tissue concentration increases proportionally to gas concentration. So if there's a 5-fold increase, there's potential then for a significant increase in the tissue. It treats only the wound and therefore avoids systemic side effects. And it overcomes, the problem that you have with oxygen having to travel through the circulatory system. And especially if you're dealing with lower leg ulcers, as you go distally, oxygen available in the circulatory system is reduced. But using CDO, we are able to overcome that problem and deliver higher concentrations, and therefore improve the tissue oxygenation at the local wound level. It does that oxygen works by increasing cell metabolism and energy production, increasing rates of reepithelialization, increasing collagen synthesis, increasing antibacterial activities, and increasing angiogenesis and revascularization. The product actually comes with a choice of pre-built dressings, which I think makes delivery very easy for community nurses, hospital nurses. And you have a choice of absorbency, as well as a choice of whether or not the dressing has an adhesive or not. We often get asked, can I use other dressings under the EO2 dressings? And yes, you can. And initially, Often we find that the exudate increases in the first 2 weeks, so you may need to add a dressing as long as it's not occlusive. And clinicians who've been using EO2 have used a wide variety of dressings, especially in the first 2 weeks. Also, how do I know what level of oxygen do I set the unit at? And it's very simple. We have a chart. You determine the wound surface area, and then you set the flow rate accordingly. Another question, how often do I need to change the dressings? And initially, with the increase in exudate, you may need to change the dressing every 2 days. But after about 2 weeks, often dressings are changed once to twice a week. But you as a clinician would determine that based on what your patient needs. Finally, if you have more questions, please contact myself, Edie, or Kathy. We are the National Clinical Consultants. Go to the EO2 website or go to the portal that the NSWOC Conference has set up. Now I'm going to turn it over to questions from our audience. Thank you all, and thanks for my 2 co-presenters.